I think I'm connected on.
જય જિનેન્દ્ર બધાને. વેલકમ. આજનો આપણો ટોપિક છે bowel cancer, and we have got two specialists here. First one is Mr. Sujay Shah. He's a collateral surgeon. He's a consultant based at Luton and Dunstable Hospital and actively manages bowel cancer patients on a regular basis. He completed a research degree from Imperial College on the outcomes from colorectal cancer and has trained at St. Mark's University College, London, and the Royal Free Hospital, amongst others. He's a fellow of the Royal College of Surgeons of England. The second speaker is Benazir Siddiqui. She is a health improvement specialist who is part of the bowel cancer screening program at St. Mark's Hospital, which is very local to us. I would like to take this opportunity to invite Dr. Sujay to please start his presentation.
Somebody, yeah. Okay. Bit too loud. Okay. Tamara badane khub khub abar, Profula Ben, Nikita Ben, and the rest of the Northwest Committee for organizing this, because actually this is a really important topic, and it's really something that we don't talk about so openly, but I think we should. And over the next 45 minutes to an hour between the two of us, we will have a bit of a talk and answer some questions. And hopefully by the end of it, there's a bit more information, but a bit more awareness and a bit more wanting to talk about things. We'll start off, next slide. Just my background. So I have been training in surgery for many, many years. And currently I work as a consultant in Luton. And bowel cancer is part and parcel of what I do on a day-to-day basis, amongst other things. So it's very natural or normal to me. But there's a lot of things about this that to everybody else, that people that don't deal with it regularly may find a little bit embarrassing, may find a little bit scary. But hopefully by the end, but I will understand that this is something that we must talk about and we must be more aware of. So the first thing, our bowel, what does it do? Why is it there? It's part of the digestive system. આપણે બધા આજે બહુ સરસ જમવાનું ખાધું, પૂરી શાક, દાળ ભાત, and every day what you eat, that gets converted and gets changed into things that are your body needs, that is essential for your body to function, and that's what your digestive system does. એટલે તમે start કરો from the mouth, મોઢામાં તમે you take a bite, you swallow, you chew it up with your teeth, and it goes down your throat and into your food pipe. ગુજરાતીમાં આવે, ગુજરાતીમાં ને બધા words મને નથી ખબર, but hopefully some of them I will get right. એટલે તમારો food pipe અહીંયા. Food goes down within a few seconds, within a few minutes. And થોડી વાર તમારા stomach, પેટમાં બેસે. ત્યાં you have a lot of enzymes, a lot of other things that come in from the liver, the pancreas, from the gallbladder. And slowly the food starts moving down your system into your small intestine and eventually into your large intestine. As it goes down there, a lot of the healthy bits, a lot of the important things get pulled out of it and go back into your bloodstream and go into your body to help you help build things up. And a chelebaki, what is left as waste, sits on the left-hand side and it waits for you to go to the toilet and pass it out. For some people, that's every day. For some people, that's 3 or 4 times a day. For some people, that's once a week. Whatever is normal. Okay. Next slide, please. Next slide. So, bowel ni વાત કરીએ, there's lots of different things, lots of different words. The main thing that we talk about, it has lots of different names. A lot of them are interchangeable. when you talk about the bowel or bowel cancer, usually what you're talking about is cancer of the colon and the rectum. એટલે તમારું large intestine, મોટું આંતરડું. Okay. And although other things are common, are there less commonly, small bowel and anus, but that is the main bit. And it's the bit, if you go back to the slide, just the next slide, sorry. It's the bit that is right around your outsides. Okay. તમારું વચમાં આટલું બધું small bowel આવે, and as the food digests, it goes into your right hand side, into your large, your large bowel, your ascending colon, તમારું appendix છે, બધાને appendix ખબર હોય. Appendix, a lot of people will have had their appendix out when they were younger. So it goes there, it travels all the way up your right hand side, up to near your liver, goes across, comes down on your left hand side, and then eventually makes its way down to your back passage, and it comes out when you're ready. Okay. And then the bowel itself has a normal lining, but I know a normal lining made up of lots of different cells. And a cancer is when the cells start to become a bit abnormal. એટલે તમે cancer જેનું કયો, lung cancer, bowel cancer, breast cancer. It's when the normal cells, but every organ is made up of lots of normal cells, and when they start to become abnormal. And there's a spectrum, which there's normal on one side and cancer on the other side. And they slowly start to progress. They don't change. One day there's nothing, and the next day there's a cancer there. Slowly over time, they change. And in some people, that can be slowly over a few months. In some people, it can be over a few years. But that's what it happens. And they start growing, and the more and more of these abnormal cells, they develop, they grow, they start to fill the organ that they're there for, and they can start to spread to other organs. And that's what cancer is, essentially. Next slide, please. So how common is it? It's the reason we're here today. Bowel cancer now in the UK is the 4th most common cancer. If you take away separately the female cancers, breast cancer, and the male cancer, prostate cancer, it's the 2nd most common after lung cancer. So it's very common, and it's becoming more and more common. Over the last 10 to 15 years or even long, the numbers are going up year on year. Okay, so it is common. It is the 2nd highest cause of cancer deaths in the UK. So although it's the 4th most common cancer, a lot of people with breast cancer and prostate cancer don't necessarily die from breast cancer or prostate cancer. Bowel cancer is the 2nd most common killer from cancer death, second only to lung cancer. And over the next 15 to 20 years, I think that will change, because lung cancer is again becoming less and less because we don't smoke as much. That's the biggest thing. So it's common and it's on the rise. The latest national numbers show 37,700 people were diagnosed with bowel cancer in 2023. And that number is fairly consistent over the last 15 to 20 years. It's in and around 40,000 every year. That's new cancers. 1 in 15 men, 1 in 18 women. So in this room, chances are there is somebody that has had bowel cancer that has known somebody else that has had bowel cancer. So it's common. Next slide. Risk factors. So with any cancer, everybody asks you, why do people get it? Why is it that I have got cancer and somebody else doesn't? And some of the things are quite common, and some of the things you can control, and some of the things you can't really control. So the things that you can't control really, age. So bowel cancer is more common as you get older. We do see it more and more in younger people now, but it is more common the older you get. And the majority of people that I treat and operate on are over the age of 65. Okay, but it is so that's something that you can't really change. If there is a family history and there is genetics involved in bowel cancer, and people that have a strong family history, people that have 1st degree relatives, so brothers, sisters, cousins that have bowel cancer are more at risk, and therefore it's more and more important that you listen to any symptoms that you have, but also get checked if you don't. And we'll talk about that a bit afterwards. If you've had a history of a bowel cancer in the past, your risk is higher of getting it again than the normal population. And we'll talk a bit about polyps. If you've had polyps in the bowel, again, your risk of developing bowel cancer is a bit higher. Polyps are simply somewhere in that stage of normal cells to cancer cells, and it's somewhere in the middle. And if you have, so again, something else that's fairly common, not as much in the South Asian population, but is becoming more common, is things like Crohn's disease or colitis. And again, if you've had Crohn, or if you have Crohn's disease or colitis, your risk of developing a bowel cancer is higher. So it is important that you regularly get checked, get screened. And finally, radiation exposure. So that's not just things like scans and things, but day-to-day life, you know, flying on an aeroplane, you have radiation exposure. Talking on your phone, you have a small degree of radiation. And some of those things you can't really control in today's day and age. So those are uncontrolled. The things that you can change, and probably one of the most important take-homes from today, diet, definitely. So diet is one of those things. And they talk about high fiber diets, which is good for your gut in general. Fiber is Gujarati diet or Indian diets generally are quite high in fiber. Fruit, vegetables, vegetarian diet is often higher in that than a Western diet. So fruit, vegetables, things that essentially have less fat and less starch in them, and are sort of natural fruits and vegetables. So high fiber diet is healthy. Physical activity and exercise. So that is really important. It's not just for bowel cancer, but for your general health as you get older. The less physical there is a good relation between the less physical activity people do and the number of cancers that are more common. Linked to physical activity and diet is weight. So obesity and people that have a higher BMI or higher weights, again, are at greater risk of not just bowel cancer, lots of other health problems. So it's very important. And other diseases, things like diabetes, there is more and more, there's increasing evidence that it increases your risk of developing bowel cancer. But it also, all of these things are also important because if you develop a bowel cancer, they affect your treatment options in some way because your fitness is affected by all of these things. And probably one that you all know about for lots of things is smoking. So smoking 20 years ago was commonplace wherever you went, outside, in restaurants, in bars. There is a lot less of that. And it's because not just of its impact on the lungs and lung cancer, but it has an impact on your health in so many different ways. And again, bowel cancer is another thing that is more common in people in smokers. Next slide. So I will talk a little bit about what to do if you have a problem, and Benz will talk a little bit about actually the screening program, which is if you don't have any problems. What are the symptoms of bowel cancer? And there are some things that are common. So as I said right at the beginning, but I know going to the toilet is a habit that is slightly different for most people. Okay, it's not everybody is normal is once a day. Everybody must go once a day, and if you don't, so if you go to the toilet, some people go 2 times a day, some people go, as I said, twice a week. If you notice a change, so if you for the last 60 years go every morning, and then suddenly you realize, actually, over the last 2 months, I have to go 4 or 5 times in the day. So a change from your normal, that's important, okay? Whether that's more diarrhea, whether that's more constipation or finding it harder to go to the toilet, if it is a change from your normal that lasts for longer than a few weeks. Brother, you've all been somewhere on holiday and you eat something funny, and then for a week, 10 days, your tummy is very upset, you have, but then it goes back, it settles down. What I'm talking about is where it changes and then it doesn't go back to what used to be your normal. The other common symptoms is seeing blood. So seeing blood either when you go to the toilet, when you finish off and you wipe your bottom, when you look in the toilet, and you should look, is there blood there? Is it Lots, is the water very red? Sometimes blood doesn't always look red. It can look black. It can make the stool look very black. Again, if you notice something like that and it's consistent, well, blood in the poo, actually, even if it happens once or twice, you should speak to your GP. If you notice problems with tummy pain or tummy pain particularly related to going to the toilet, see your GP. And then more common things, more general things. So weight loss, if you're having difficulty, night sweats, all of those things could be a symptom or a sign of bowel cancer. They of course represent other things as well, but it is one of the things. And actually, when you go and see your GP, one of the most easily accessible referrals to a specialist is through the bowel cancer, the colorectal 2-week weight referral. If GPs are not sure what's going on, there's you've lost a little bit of weight and they will send everything. And I see it on the other end, lost a bit of weight and have a headache. Let's refer them for bowel cancer. And it's frustrating from our end, but it's important because actually it means that people come through the system, get their checks done, and you have an answer. Okay? So anything from here that you are worried about, as I said, a change, you should go and see your GP. And your GP will listen and they will ask you some more questions. They may do some blood tests initially. They may send you off for some stool tests. And Benz will talk about that in a little bit more detail. But generally, they will refer you on to the hospital. And kai ne kai parishan hoy, kai worry hoy, go and see your doctor, talk to your doctor. And if you don't get the response you want the first time, go back again if you're worried, If you've been there and it'll get better 2 weeks. If it hasn't gotten better, don't leave it alone. Go back and see the GP. Next slide. So I've talked so far about if you have symptoms and problems and what to go and see your doctor for. I'm going to take a short break and Ben is going to talk about screening, which is where you don't have any problems, but the government they send you some tests to do to try and pick up potentially bowel cancers or other findings in the bowel early. And at the end, I will show you why that is so important. I'll pass on to it.
Hi, can you all hear me? Yeah. I don't know why it always has to happen on my turn. Thank you, Dr. Shah. You have covered wonderfully each part of the bowel cancer and screening. I don't know why I'm here, but it's fantastic. I have learned a lot and definitely using your slides for my next presentation. So I'm Benzir from St. Mark's, and I'm going to talk about a few things today, mostly already covered, so I'll be very quick. Can we have the next slide, please? So we will, as we have already learned a lot from Dr. Shah about bowel cancer, facts, symptoms, risk factors, but I'll be talking a little bit about barriers and prevention as well. So can we have the next slide, please? So we have already learned about bowel cancer, but I'm just, as Dr. Shah already mentioned about polyps and how it becomes cancer, I just want you all to have a look like how it becomes cancer, and then at stage 4, it goes to distant organs and spread in our body parts. So just that, and then I'll have next slide, please? He already mentioned the facts. So these are the facts we have noticed between 2017 and 2019, and we are working on the next evidence for the next year. But we have seen number of nearly 45,000 cases during this time. Sorry, that's not me. And then the number of deaths, and we recently have seen the increase, and it is increasing each year, the number of cases we diagnosed and the number of deaths we get because of bowel cancer. Can we have the next slide, please? So this is also wonderfully covered by Dr. Shaw already, that change in bowel habits and blood in stool or your poo, abdominal pain, discomfort, or any extreme tiredness or weight loss if we notice. So normally we tell people that if you see these symptoms which last more than 3 weeks, we advise people to directly get in touch with your GP. That's the best way. Obviously, if you get symptoms and then you are contacting your GP, you will be on a symptomatic pathway, not on the screening pathway. So this is another difference, which I'll be explaining in the next slides. So if you already have symptoms, you have to get in touch with your GP. Let's say if somebody notices that, oh, I have observed weight loss. Let's say about me, I was deliberately losing weight, obviously, because of my diet. But if you notice that there is no changes in your diet or routine, but you're still losing weight, so we advise people, and it's more than 3 weeks, or change in bowel habits. So get in touch with your GP. That's the best way. And do not ignore the symptoms. Can we have the next slide? Tap more. One more time. Thank you. So basically, NHS bowel cancer screening program is an asymptomatic program, a screening program. We want you to take part when you do not have any symptoms. As I mentioned earlier, if you develop any symptoms and then you are contacting your GP or contacting the hub to get screening kit, that is a different pathway. It's symptomatic pathway. And we want you to take part when there are no apparent symptoms. Unlike Dr. Shah, my Gujarati is not good at all. So you all can ask me questions later and I'll try my best to explain Hindi, Urdu, or English. Thank you. Can we have the next slide? Yeah, I'll show them there. So as I mentioned that screening is basically for prevention. We want to prevent you, as we all do MOT for our cars. You can say screening is prevention for our body, like for ourselves. We have to screen before we have or develop any symptoms. Can we have the next slide, please? I'm loving it because everything is already being told, so I'm being very quick. So normally when, let's say, 100 people get invited for screening, out of 100, only 6 or 7 get invited for further test. And this is not because you have cancer. This because you had blood in your poo, in your sample. It could be because of any other reasons. There are piles or etc. Like could be any other reason. It doesn't mean that you have cancer. So when the clinical team get in touch with people and invite you for next stage, is just for a procedure to check that if there is any symptoms, any polyp or any growth in your bowel. So it's basically a normal, regular process, but it doesn't mean that you have cancer. So we tell people that when you get invited for next stage, do come for the procedure, like to get tested for further tests. Can we have the next slide, please? So as we already learned about the risk factors, I'm just going to be very quick about these again. I will particularly talk about like myself and my family. We were not aware of the quantity of fiber we have to have in our diet. So ever since I started learning about diet and being healthy, I have found out like, okay, I'm just eating rice. I'm eating gluten. I'm not eating fiber. So, for example, I wanted to find out which goes well with my Indian diet. Like, I do not want something which doesn't go with my dal chawal, right? So I started sweet potato, you just air fry, or I would have saturated fats. Let's say the best would be avocado. So these things, like including in your diets, and as Dr. Shaw already explained, that every bowel is different. Every person have a different bowel. Like maybe some people they get develop symptoms earlier, but some will get later, or some may never get the symptoms. They are blessed; they just never get symptoms, but or cancer. But then we have to, listen to our body and find out ways which suits us and our bowel, our symptoms. Some people, they do a lot of physical activity to avoid any risk factors or symptoms. Some eat healthy, and I'm one of those. And then some are like me. I just hate going to the gym or running or walking. But you have to listen to your body, which suits the body, and you have to follow that and avoid the risk factors. We learn about smoking, but we also have to be careful about passive smoking exposure. I mean, I'm just walking in underground and somebody is smoking in front of me outside underground. So I would like to avoid that because I'm not even smoking, but I'm getting that smoke, inhaling it, right? So these things we have to be careful, like little things, and then we are fit to go. Like we can consider ourselves healthy, and just keep an eye on the symptoms, and it can develop because of any other reason. So if you feel that there are something bothering you for more than 3 weeks, get in touch with your GP. Can we have the next slide, please? It's already covered, so maybe we can skip it. Thank you. Talking about barriers, this is the most interesting part, I would say, I have come across ever since I've been doing these presentations. So we go to different community, and we have learned that every community have a barrier or reason to avoid or not taking part in the screening. Let's say my last experience with Somali community, where they would not even talk about bowel because it's very offensive word in their language. So somebody came to me that, oh, it means womb. We don't even have a word for bowel. So for example, similar way, a lot of people, they think screening is when you have cancer. That's why I'm getting invited or getting this kit to take my sample. But no, it's when you do not have any symptoms, or we want you to be aware of each and every part of screening, that when you send your sample, the next stage would be if there is any blood in your poo, we will get invited for next stage, but that doesn't mean that you have cancer. And other factors like females, they tend to avoid, or from our community mostly, they are like, they concerned that if I am sending my poo in the kit, maybe people will find out it smells. No, it doesn't. It's safe. There are other reasons, like we get a lot of calls from wives or partners saying, oh, my husband or my partner is asking what is the shelf life. He's been keeping this kit for 2 years, so please don't take that. Just send a request for a new kit, but the shelf life is only 1 year. Or if it's past 6 months, we do not advise you to use the kit. You can send it, request a new one and send the sample again with that. Can we skip the next slide, please? So as we talk about prevention, the prevention would be to avoid the risk factors, taking part in screening between the age group of 50 to 74. Before and after, you can always self-refer yourself if you have any symptoms. At 50, 75 years and above, you can always self-refer. Screening can remove adenomas when before it becomes cancer. So as I mentioned, and Dr. Shah explained in detail about how a polyp or a growth can become cancer if we don't pay attention to the symptoms. So basically, screening is when before it becomes any cancer or turn into a cancer, we would like to remove it. And it's much safer and easier at that stage. And obviously, early diagnosis is better than cure. So as a prevention is better than cure, as we all know. Can we skip that? So this is how the fit kit looks. Please raise your hand how many of you have received it or done it. Oh, very well done. So you have already seen the kit. So you receive on your birthday a gift from NHS like this. After every 2 years, once you turn 50. And that's how it looks. And it comes with an envelope, which gives you instruction as well in the back and all the details about the screening. And then this envelope. So basically what you have to do, you have to put the date. We'd never ask people to put their name or any other information, just a date when you're collecting the sample. So how you collect the sample, this is another thing, like, please do not use the rocket science. We have had so many, had to discard these kids because the sample was through a rocket science probably. It's very simple and I don't mind explaining it to anyone. So normally we do not encourage takeaways, just to let you know. You can take any old container and place in your pot and place a tissue under the container. And what you have to do to collect the sample, you just open the kit and you see these grooves tiny here. Please do not shovel it. You don't have to like load it. You just have to run through it and just when you hear this click, so it's logged. So nobody will find out what's inside it. But please, 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 we had to discard so many because it was loaded and not properly clicked and not dated. So we request people to don't do experiments. This is not NASA, not rocket science, just a normal sample collection. And then you can put it in the envelope and post it through the post. And that's it. And when we receive it, we analyze the lab analyze the results, and you get invited if there's any blood for any other reason, could be, or any reason you have blood in your poo, you will get invited for the next stage. But if you have any questions about how to collect sample, what about it gets diluted, the water in the pot or something, you can ask me. But it's very simple. If you use a tissue or a kitchen towel, you can just collect it without diluting or any water going in the pan. Can we have the next slide, please? So yeah, as I mentioned earlier, that when we invited 100 people, 98 do not need any further tests, but 2 may get invited because there was blood in their sample, and it could be any other reasons. Can we have the next slide, please? So after that, we have the process, like, as I mentioned, that you will get invited. And even if somebody gets diagnosed with cancer, let's say they had growth, it can be easily removed at earlier stage. But if it's not even early stage, if it's late stage, we have the best surgeon with us. And St. Mark's is the best gastro hospital in the country, as we all know. So you really are in the best hand. You don't have to worry about, but do not miss appointments and do not skip the procedure. Like, we really encourage people to go ahead and get it done. Can we have the next slide, please? So yeah, you can skip it. I just don't like to brag back and back about St. Mark's. So you are in the best hand, as we are one of the best hospital in the world and second best in the country. Can we skip the slide, please? So if you, as I mentioned, you can self-refer. You can use the first number, helpline and self-referral. And then that's my team lead, Andrew Prentice, and that's me. You can contact us through emails or through landline, and we are happy to help, but you can always self-refer yourself as well. So That's us. If you have any question, please feel free to ask. You know, in my last presentation in Somali community, I asked a lot of people were there. If you have any question, you can ask me. They asked me if I'm married. Please ask about the presentation, not about my personal status. Thank you.
Thank Thank you. Thank you so much, Benzir. That was an excellent presentation. I'm really sorry that a lot of the stuff that we covered was covered by both of us, but I think it's really important because actually it's an important point that we're trying to make here, and it's an important point. It doesn't matter if you hear it over and over again or if you hear it once. It's at the end of the evening. Hopefully, some of the message has gotten through. So. Benzir बात करिए about if you don't have any symptoms, kai lakshana na hoy, so you get the kit in the post. Even if you have no problem, you shouldn't ignore it because sometimes you find things much earlier before you start to have symptoms, and it's important to do that because it means that we can treat it in an easier fashion. I talked a little bit about if you have symptoms, problem what do you do and who do you go and see? Once all of that has happened, then what happens? So you see your GP or you do the screening test and you get called back. Pachi, what happens? And that's the point where everybody starts worrying. Okay, I've seen the GP, nobody's called, nothing's happened. And these things take a bit of time, but in the background, there is a lot of things going on. So I'll just now talk to you about what maybe to expect if you get called to hospital, or if you get referred to the hospital, and we will just go through that in a step-by-step way. Next slide, please. So the first thing is when you go and see your GP, and I know they've got 5 minutes, 10 minutes, it's impossible to get an appointment. You have to call between 8 and 8:01. Go and see your GP, get the appointment. The most important thing when they refer you is to make sure that your contact details are correct. You talk to them about symptoms, everything, even the screening. The most important thing is that your contact details are up to date. And that's not just your address, but your phone number, and if you have an email address. Because actually what this triggers is something called a 2-week wait referral. Just click again. And the 2-week wait referral doesn't mean that everything happens in 2 weeks. It's just a simple way of, it's an expedited way of people that we are worried about that may have cancer. Not everybody has cancer, but we want to get them seen quickly. We want to get them tested quickly, and we want to tell them, don't worry, this is not cancer. Or if you do have cancer, we found it, let's make a plan. Click again. So you should be seen within about 2 weeks' time, and that number doesn't always happen, but you should be seen within about a 2-week period. And then after that, you should have an answer to whatever the question is within about 4 weeks. Okay, and that is what this means. And it's so important because often we get these referrals, and then you call a patient and then they don't answer their phone because the appointments often will happen within a few days. So there's not enough time for the post to get to. So we call and there's no answer, and you can't get hold of them a second time, a third time. And that alone means there's a little bit of a delay. Next slide, please. Once you get referred, once you get the appointment, it's not, 10 years ago, it would be very standard. You go to the hospital, you go and see the consultant, you sit with them for 20 minutes, half an hour, you have a long conversation. However, in order to speed things up, in order also to make things more efficient, your first appointment might not be in the hospital. It might be over the telephone. It might be a virtual appointment, so over a video screen, so a bit like Zoom. And it might not even be with a doctor. It might be with a nurse initially, because actually a lot of the questions that you are asked, a lot of the initial bits of information, it's about information gathering and planning for the next few tests. So it's okay for it to be a telephone, a virtual appointment. If you get called in, again, it doesn't mean there's anything to worry about. Often patients that are a bit older or much younger will get called in initially because you want to see what they're like. And then one thing that I would say for all of you is have not just your problems, what the problem you refer to, but any other health problems that you have ready. Because the person that is doing your appointment needs to make a decision, okay, are you going to be fit enough to do some of these tests? And how quickly should we get them done? And so it's important that we have an idea, okay, what your health is like overall. Next slide, please. And that initial test, and some of this might be at your GP surgery, they'll do a few initial things like your blood pressure, your heart rate, your height and your weight, what the main problem is, and any other problems that are associated with it. They may do some other samples, some urine samples, some stool samples if they've not already been sent, and some additional blood tests, and they look for specific things. And again, not to be embarrassing, but sometimes you might need to have specific tests or examinations to examine the tummy, to examine the back passage. And again, it can be embarrassing when people go for these sort of problems, but for the person on the other side, this is day to day. And what you've got to remember, okay, this is about trying to see if there is a problem, and if there is a problem, how do we deal with it? So we've got to get past that. Next slide. So with bowel cancer, usually the first next test is something called a colonoscopy or an endoscopy. An endoscopy simply means a camera test to look inside. And a colonoscopy is a type of endoscopy where they look inside at your colon. So you can have an endoscopy to look in through your mouth into your stomach. But for the purposes of this, it's mostly to look into your bowel. And again, it's uncomfortable. Most people, again, St. Mark's is a world-renowned center here, and we have it at our doorstep. They probably do the most number of specialist endoscopies in the UK. But most people will have these tests done with them being awake. So people ask, how can I have this test where it is a test where they put a camera into me and I'm awake? But actually, most people will have thoda dukha hota hai, thoda, it's a little bit uncomfortable. It takes about half an hour, 45 minutes. But most people will have it with them awake. They'll offer you something to help with the pain, so a bit of painkillers, something to make you a bit drowsy. And again, but like, oh, I was awake, maine badu dekha to. And then the purpose of the medicine is not to make you sleep completely, it's just to give you a little bit of relaxation and help a little bit with the pain. It's usually, as I said, about half an hour to 45 minutes, and the main aim is to have a look all the way around and check. The worst bit of it, before that, they send you, I'm sure some of you will have seen this, they'll send you something to clear your bowel completely. And actually what most people say is that's often worse than the actual test. Yeah, proper julab. Yeah. Sometimes if a small number of people just can't manage it with them awake. So sometimes they will give you after that they'll try with an anesthetic or a little bit of a heavier thing. But most people will manage this, and it's a camera that looks all the way around. Next slide. And that's usually the first main test for bowel cancer. Sometimes it may be that we feel that you're not fully fit for that, and instead of that, you might have a scan, a CT scan, or it might be that you feel that actually it's not entirely necessary. We're not very sure that this is just a bowel problem, and so we'll do a CT scan. And a CT scan, there's two types for the bowel. One is where they, again, give you a strong laxative, a strong julab, and then do the scan. And other is just a normal CT scan. So you go in a tunnel, you spend 10 to 15, 20 minutes in through there. And then at the end of it, you get, it's like you've been sliced up like some bread. And then you get lots of pictures that you can see on a screen to see if there's anything going on. Occasionally, we will also have an MRI scan, but all of this will often happen afterwards, an ultrasound or a PET scan. Next one. And if you find anything, so especially on the colonoscopy, if there is a lump there, if there is a polyp there, we take some samples. So biopsy, just a little sample of the tissue to see what exactly is this. Okay? Is it normal tissue? Is it healthy tissue? Okay, is it a cancer or is it somewhere in between? If it is a cancer, what sort of a cancer is it? What grade of it, and are there any specific changes in it, any specific mutations? Because now there's more and more medications that are available that will respond to different things depending on what it looks like under the microscope. So it's all important. But all of this takes time. So from the time you first see your GP to the point where you have the results of a biopsy can sometimes be up to 4 weeks. And it can be a worrying time. But it's taking long because there are things happening in the background. Next slide. So I put this slide up here because, as Ben said, that not everybody that gets referred for a colonoscopy or for after screening or after this has a cancer. Depending on where you look, that number is anything from less than 1% to about 12, 13%. So most of the people will not have a cancer. So again, it's worrying. You're being referred for this as a suspected, but most people will not have a cancer. A number of people will just have a normal test, and whatever problems they had, or from the screening point of view, the test results were because something had gone on the while and it's now settled. Other things that you can find. So polyps, the first one in the corner there, if it projects clearly, is a polyp. And what is a polyp? It's abnormal cells that are somewhere along the line of normal to the cancer, and they are starting to move along that way. And that's why screening is so important. So polyps, that's small, that's magnified, that's probably less than a centimeter in size actually. So it's rarely going to cause any problems, any symptoms. It's rarely going to cause bleeding, your problems with diarrhea or constipation, but it's there. And if we find it there, at the time of your colonoscopy, it might take a bit longer, but they can take it off. They take it off and they send it off to the lab, and it tells you, this is not a cancer. If you leave it alone, in 10 years' time, that might have become a cancer. So it's why screening is so important, because you can pick things up very early and you can treat them much easier. So we could, during that same endoscopy, colonoscopy, it gets dealt with, it gets done, and that's it. Common things now, again, to do with Western diets, more and more. We see it more in Caucasian populations, but actually you are seeing it more and more in Asian populations. The other picture is something called diverticular disease. Some of you may have heard of it, diverticulitis. And it's not a cancer, but it's something that often causes the same symptoms as cancers. So people will have these problems and they'll find them on the colonoscopy. And then you can start to talk about how do we manage it? What do we do? And also, don't have a cancer, can deal with other things. Colitis, the corner and the picture in the bottom, it looks very inflamed, looks very red, it doesn't look very, and that again can cause a lot of similar symptoms. So we pick up other things on colonoscopies, not just cancers. And common thing for bleeding particularly is hemorrhoids, piles, and they cause some bleeding and people worry, but they are something that you can deal with quite easily, again, with changes to your diet, changes to how you go to the toilet. But again, if you need an operation, it's something you can deal with quite easily. The important thing is that you've had the tests, you make sure that it's not a cancer, and then you deal with whatever else there is. So cancer is in the middle there, but remember that's only a small number of people out of the ones that get referred. Next slide. But Ajay, we are here to talk about cancer anyway. So we'll go back to this once again. I think this is the first slide that Benz has already beaten me. So stage of cancer, okay? And again, I'll come back to one slide right at the end. Stage of cancer. If you pick it up early, stage 1 is when it's become an early cancer. It's not a polyp, it's become an early cancer. And stage 4 is when it's an advanced cancer and it's gone to other organs. And in order to decide that, in order to decide what are the best options for treatment for you, all of your information, including what your health is like, including how you presented, what you first went to your doctor for, what your scans showed, what your colonoscopy showed, and then what it looks like under the microscope. You have a team of specialists that sit down together and decide, actually, this is probably the best sort of treatment. Now, generally, with colon cancer, stage 1, 2, 3, the first treatment, and often the only treatment, stage 1 and 2 at least, is an operation. And that's all you need. But with rectal cancer, sometimes there are options for giving you chemotherapy or radiotherapy beforehand, before you have an operation, and then having an operation. So all of this information gets put together, and then you come together with a recommendation, and then you will come back and see your specialist, usually the surgeon. So this will often take 4 or 5 weeks. Next slide. So as I said before, and you can see this and read this, but there are lots of different options for treatment for different cancers. But broadly, for colon cancer, the first treatment is usually surgery. And then after your operation, depending on what it looks like under the microscope later on, you may be offered chemotherapy. And chemotherapy is usually, in that situation, it's a bit like an insurance policy. Okay? You've gotten rid of the cancer, but to reduce your chance of it coming back again, you may be offered chemotherapy. And then rectal cancer, sometimes you have treatment before an operation with either chemotherapy, radiotherapy, or both. And nowadays, with a lot of newer treatments, there are more options available to treat things without an operation in the first instance, and probably in about 10 years without an operation, full stop. So we're getting better at medically treating some of these things. Okay, next slide. So what do you do? So you get the call from the hospital saying, okay, can you come back? We've got all your results. You're going to come back for an appointment. Okay, come back and see the consultant. And of course, there's lots of questions going through your head, and somebody will talk to you about what they've found, what they think is the best treatment for you, whether that's an operation. But it's important you go there with a little bit of an idea. Okay, what do I want to know? What is important to me? Often people come even now. So I work in Luton. Luton, there's a very big Asian, predominantly Bengali or Bangladeshi and Pakistani population, but big Gujarati population. And often people will ask me, what would you do? Tell us what to do, Dr. And that's often important, but there are some things that are personal, and there are some things that are different, and there are some things that you have to decide, okay, if they say, having an operation and being in hospital for 2 months versus not having an operation, what is important to you? So it's important to have a set of questions about what you think, what you want. What happens if you don't have the treatment that we're offering you? And that's becoming more and more topical now, because a lot of the treatments, particularly later on, can have other effects, other side effects, and people will say, actually, you know what, I don't want any specific treatments. What will happen if I don't have the treatment? And it's important to ask that. And I work and we live in the NHS, where actually there's lots of support available. And that's the other thing to ask, is locally, what else? So there's usually a nurse specialist that is there. What other support is available to me? Whether that's psychological support, any financial options. Gujarati there's so many information leaflets nowadays. Everything is translated from English into lots of different languages. So if you don't fully understand in English, you ask. And then you say, okay, look, mana, is not, so have you got anything else, anything written, or is there an interpreter there if they don't? And you must understand why you're there and what you're being offered before making a decision. Next slide. So briefly, I'll talk a little bit about surgery, and there's lots of different options, and we've come a long, long way from where we were even 20 years ago. And as I said, early enough, even early cancer, sometimes we can treat without a full general anesthetic, either at endoscopy, and you go in for an afternoon and you leave hospital the same day. And it seems ludicrous, and it seems like, oh no, I've got a cancer, you must be in hospital for 2 weeks. But actually now things have progressed so far that there are so many options. A lot of the major cancer operations I do, sometimes we'll go home the next day. So, they've had major abdominal surgery, they've got few scars on them, they'll go home the next day. And Yeah, so there's so many options. Next slide. And as I talked about before, in addition to surgery, there are options for chemotherapy and radiotherapy either before or after. And again, they may be tablets, they may be through the drip, but usually a lot of these things are just as a daycare. So you don't need to stay in hospital now for long stretches of having chemotherapy for bowel cancer. So, okay. Next slide. And people always ask, what is the best treatment for? And again, this is where it becomes very nuanced and personal. So where exactly is the cancer? What specific types of cancer is it? Has it spread to the lymph glands? Has it spread to other organs? What is your overall health and fitness like? There are, even chemotherapy, but surgery certainly, it takes it's like running a few marathons over the course of a couple of days. So what is your fitness like? Are you able to sustain that? And what are we aiming? Are we aiming to cure you? Are we aiming to just reduce the burden of the disease and prolong things slightly? And what are the side effects as a result? So you must ask these questions, and you can only ask them if you've talked about these things beforehand. Next. So this is the last, this is pretty much the last slide. And this is why screening is so important. This is why if you have problems, it's important to acknowledge them, talk about them, and go and see your GP quickly. So this on the left, 10 people out of 10 people that are diagnosed with stage 1 cancer. So that is cancer of the bowel cancer that is early, it's within the bowel itself, and it hasn't even spread to the outer layers of the bowel. It's early. 9 out of 10 people, so 90% will be alive 5 years later. Okay, and that's including all cause. It's including the one person that might get hit by a bus instead. So 9 out of 10 people will be alive 5 years. But if you are diagnosed with stage 4 cancer, so it's later, it's spread outside the bowel, it's gone to the lymph glands, it's gone to other organs. 5 years later, 9 of those people will be dead. Only 1 will be alive. So there's a big difference in whether you get diagnosed early or whether you get diagnosed late. There's a big difference in your outcome and your survival. Bowel cancer is very treatable. The majority of people, if you catch it early enough, will be alive 5 years later. But if you catch it late, it goes from being treatable, curable to less so. And it's why screening is so important. But in addition to screening, if you have a problem, seeing somebody early and getting it checked and tested. And hopefully getting it checked and tested to be told that you don't have cancer and it's something else and we can treat it. But if you do, then finding it and working out what to do and planning. And I think that is it for now. Thank you so much.
Thank you, Sujay and Benzir. That was really, really good. Absolutely excellent. How's everyone feeling? Feeling okay? Yeah? So we're going to do... I know you want a cup of tea, but no tea today. We're going to do a few hand holding exercises now. So what have we learned today? What's the most important thing we've learned today from both the presentations here today? Screening. What else have we learned? Thank you. Brilliant. Very, very good. Thank you. What else? Don't ignore the signs. This. Don't wipe away the signs. Yeah? What else? Pursue kawan Umesh bhai. Fiber. Fiber masuk included. Ek example apo. Ladu. No, no, not ladu. Not ladu. Fruit and vegetables. Absolutely. So we're doing this series of talks about cancers. We covered bladder cancer. We're covering bowel today. Lungs are going to get covered on the 23rd of November. And then in February, we're going to do another very important topic. And the reason we are able to deliver this to the community is because we applied for a grant from Royal Marsden Hospital and NHS Cancer Alliance. They very kindly have provided us with some funding, which is why Amitamne dinner apiseka, but no tea. And that means that we've been able to deliver these 4 events for the community to really educate ourselves, ask the right questions. Sujay, you said 2 very important things for me anyway. It's understanding that we are all individuals. And I think you said it as well. So what is our normal? Like I know people who say, oh, who I target toilet manager, and I'm really worried because I think something's really wrong with me. 8 ના સાડા 8 કે 11 થઈ ગયા તો they are really panicking. Yeah. And that's what you were trying to say. It's not, those things are important to notice, but actually the things to notice more are those things that we've just talked about. So we've got some wallet cards here, just to remind all of us what the symptoms are, the signs are, and what we should be doing. And then there's this. What is this? No. It looks like a loo roll, but it's very important because it's got lots of really important information. And there's a, can you see that QR code? Yeah. So the QR code also takes you to a website that gives you a lot more information. So when we're finished, come and take a sheet each, not the whole roll, 1 sheet each, okay? And the wallet cards as well. We have been doing these talks for a long time, certainly since the pandemic, and we were doing them originally online, and now it's so good to have everyone back here, face to face, in a room where I can see your faces, talk about tea or not tea. And we've encouraged always that the community should have these open conversations about topics that are actually quite challenging, quite difficult. Often we want to hide them. Often we want to hide from them. So today I'm really delighted that we have somebody from our community who has been through this process, went through the screening process, was found to have cancer, but has been treated and is here today to share the story with us. I'd like to welcome Priti Ben, please, to share that with us. Can I just say thank you, because that is such an important thing to do, to actually volunteer and say, I'm happy to talk about this. Thank you.
Thank you very much, Prafula Ben, Nikita Ben, for inviting me here today. Thank you, Mr. Shah and Ms. Siddiqui, for a wonderful presentation. Yeah, my name is Priti. I know quite a few of you here, and some of you might be shocked to hear this, but I myself never imagined I'd be standing here talking about bowel cancer. I got diagnosed 5 months ago, and well, a few months before that, I had bleeding. It was just spotting, and initially I thought, oh, it's piles. I knew at the back of my head I should do something about it, but unfortunately my circumstances were such that I couldn't do anything about it. My mother was quite ill. I was looking after her, so that my health had to take a back seat. But it so happened that I received a fit kit in the post, and I sent it off, and I knew things were not right. And it was no surprise when I received the message from the fit kit, bowel screening, to say, can you please come in for further testing? So I received a call to call me in for a colonoscopy. But the earliest I could do that was after, unfortunately, Mum had passed. So 3 days after her funeral, I had a colonoscopy. My family has been through colonoscopies, so they were advising me to take sedation, which I did. Sedation just makes it easier, to go through this process. And I was awake. I could see what was going on. I could see blobs and whatnot. It didn't really register. I don't know, because of the sedation maybe, but I sort of knew things not okay. Then came out of the colonoscopy. It's not as hard as you think, yeah? Don't be scared by it. Once you've done it, and if you have sedation, it's okay. You don't even feel a thing. So I was waiting in the waiting area after the colonoscopy, waiting for the doctor to tell me what the results were. And I received a phone call. And it was from the hospital trying to book me in for the next stage, which was a CT scan and MRI scan. So of course I knew at that stage, it's not good. Yes, I was a bit worried, but I thought, okay, let me wait and speak to the doctor and see what they've got to say. And because I was under sedation, I had arranged for a friend of mine to come and pick me up. And the nurse was so lovely. She said, would you like to call her? Ask her to be with you. And I said, no, oh, I'm a big girl. I can manage this. But she said, no, just call her. So I called my friend, and we were there together when the doctor broke the news to me that I have bowel cancer. They could see it during the colonoscopy. It's basically a large blob. And then, of course, because it's through the bowel screening program, everything happens so quickly. I mean, this is not my first rodeo of cancer. I've had it before. I had ovarian cancer about 10 years ago. I had major surgery then. Then my mind was in a turmoil. Not just from the news, but also from, Mum not being there. Luckily, I've got wonderful family, wonderful friends, and everybody's really supportive. I managed to speak to a couple of people who had been through this, and they're really young. I'm 62. They were really young. They're in their 40s, and they'd been through this. So I thought, if you can do it, I can do it again, So anyway, I got invited for CT scans, MRI. By the way, the bowel screening happens at St. Mark's here at Northwick Park, but St. Mark's, part of it is at Central Middlesex. So a lot of the testing will go on at Central Middlesex. So the CT scans, MRI, went through all that, then had an appointment with the surgeon, who then explained what to expect, told me what the results were or what they could see, and then what to do next. And surgery was the next step. Yeah, surgery is hard at the best of times. They said that they were going to try and do keyhole, but because of my prior complications and surgeries, even though they tried to do keyhole surgery, they had to still open me up again. So from when I had my colonoscopy in middle of May, my surgery was at the end of June at Central Middlesex Hospital. I was in hospital for 18 days. And in that time, I was not able to eat anything for 2 weeks. So I was joking to my family, I've done double latai, 2 lots back to back. So things must be great for me now. yes, it's painful, but I have to say the whole team from beginning to the surgery, the spell screening team, the people I spoke to in between, people making the appointments, the testing, the screening, the surgeons, the nurses, they were all absolutely fantastic, really, really good. And I'm so proud of the NHS, you know, for this service that we have. Anyway, I came home after surgery. Yes, it was difficult, you know, can't move and it's pain and all that, but it gets better. So I was recovering. And then the next stage, you know, they think about the next stage, about what to do, because during the colonoscopy, they'd taken biopsies. During the surgery, they also take samples and lymph nodes to get them tested, to see, you know, whether it's spread. I was quite lucky that it hadn't spread. However, as a preventative measure, they still recommended going through chemotherapy. So the chemotherapy, I've started that. The Macmillan team at Northwick Park handle all of that. And I am on tablets, tablet chemo. So I take tablets every morning, every night for 2 weeks. And then I have a week's break and then I start all over again. And that goes on for 6 cycles. I'm on my 2nd cycle. And in the week's break, the chemotherapy team call you in to do their tests and, you know, just check everything's going okay. And then next week, I've got an appointment with the oncologist. So you're well looked after, you know, they do check and make sure you're okay. There's a lot of support available. I don't think you can fault it at all, but I would highly, highly recommend everybody, you know, does the fit test when you get it through the post. It's amazing. I was talking to other friends about it, and the number of people, I think it must have been 4 or 5 people who told me, oh, I just throw it away. I don't bother doing it, you know, but please don't, you know. It's for your own health, right? The sooner it's diagnosed, the better it is for you. The other thing, what I was impressed with all the stuff here, but one of the things, my personal observation is after my first cancer, I totally changed my diet and lifestyle. I was always vegetarian, but I became vegan, so following a plant-based diet. And I still got it. And one of the things I am personally convinced about is stress. You know, stress is something that wasn't mentioned here, but it can really harm our bodies and we don't realize in what ways. And I have been under a lot of stress, you know, and I know that that could have been a big factor in me getting cancer again. So please, you know, don't ignore the signs. I knew there was something wrong. I think you do. If you listen to your intuition, you know something is not right. So please heed this. And you are in good hands. Lots of amazing treatment available now. And yeah, if we get it again, we get it again. We just move forward, you know. Not a lot you can do. We're all going to go one day. So, yeah. Thank you.
So thank you, Priti Ben, for that very honest, open conversation and sharing your experience with everyone here. We're going to do the Q&A now. Today if you've got a question, maybe put your hand up and we'd like you to come here to ask a question. And if you know who you'd like to answer the question, perhaps you can mention that as well. Just want to say a huge thank you to Sujay Pai, Ben is there, and of course Priti Ben for, so very busy schedules, I know. And Sujay Pai, you were here at the bladder cancer talk, and I know you heard parts of that conversation and you contacted us after that. So really wonderful to have somebody from our own community doing this with us today. And thank you very much for giving the time and sharing all of that with us. I know you're going to get some Gujarati questions soon, so be ready for that. Maybe not you, but you will try Hindi. Wonderful, great. So part of this project that we are doing with RM Partners and NHS Cancer Alliance, there is information available in all our languages. And in fact, yesterday I recorded a video in Gujarati for them talking about bowel cancer. So that video, they will be also circulating quite widely to everybody. And the main aim of our project is actually to educate the community, but also to encourage all of you to ask the questions that you may have, because questions are really important. Sometimes apra magaj ma kai hoy, pachi magaj ma emnem ghuta tu re, but apre koine na puchen, pachi we listen to fake news on WhatsApp. Yeah, please don't do that. The other thing I said, and I said it last time as well, Google is fantastic, but badu Google man nahi jowanu ne badu nahi manwanu, because sometimes it is actually not helpful. Yeah. Okay. We're going to take the questions now, and yeah, I am Joe, and then tell us who you'd want to ask the question of.
No.
That's okay. That would go.
I can do that. This is mainly for Mr. Shah. In terms of death, 33,000 deaths you referred to earlier. Do you have ethnicity breakdown of that? No, the female you already, yeah, 1 in 15 and 1 in 18. I talk about whether the Asian population, especially the vegetarian population, is more susceptible to bowel cancer because of the type of food that we eat.
So, yeah, very good question. And I don't have statistics off the top of my head, but what I can tell you is it is less common in South Asian populations, but it is becoming more common. And I think that is a few things. One is living in a Western society, diets have changed significantly, lifestyles have changed to an extent. We are also better at talking about this than maybe 10 years ago, 15 years ago. And then we're also better at finding bowel cancer, and we're also better as a community of not dying of other things. So 50 years ago, bowel cancer was really not talked about in Asian communities because it wasn't really a problem. If people died at a young age, they often died of heart trouble. They died of things that we didn't really know about. Now people are living longer, and it is definitely on the rise overall.
The question for Ms. Siddiqui, and how does one, if there are no symptoms, how does one convince the GP that I'm over the age of 75, how do I convince him that I need a referral for a bowel cancer test?
No, so if there are no symptoms, you do not have to go, right? If you observe any symptoms for more than 3 weeks, then you can contact your GP for self-referral. Or you can contact us direct on the, to the hub. Yeah, hub for self-referral.
Thank you.
And sorry, I would like to answer your previous question, add just to it. That it used to be, as Dr. Shah said, it used to be less common, but we have recently, so we cover London Northwest, Harrow, Hillingdon, Brent, and part of Ealing, 4 wards from Ealing. what we used to observe up until 2021, that white others, they were more likely to get bowel cancer, especially females in white others. But now we, as Dr. Shah said, South Asian community are picking it up. And that could be, there are different reasons which we are still studying the reasons. But one of the reasons is obviously diet and lack of physical activities. And as Preeti said, stress. Yeah.
Okay, thank you.
The screen age in the UK is, or in England and Wales, is 50 to 71. And it used to be less, it's now. They are widening it over time. And it's to do with funding and resources. So you can request screening outside of those ages. You, not through your GP, you go direct to the bowel cancer screening. If you go on the website locally, it's not but you can request it outside of that. There are a few other, sort of hoops to jump through, but you can request it. It's just to do. Thank you.
Thank you. So one other important point to make is about research, and you referred to it in terms of studying the statistics. Apra loko shene research ma bona thimanta. And when we are invited to be parts of research studies, we're often saying we don't want to do this. And there's a lot of reasons for that. And part of that is also mistrust about what's going to happen with the data or whatever people find out. But research is very important. And this is how new treatments can be introduced as well. So if you ever get the opportunity to be able to do and take part in a research study, please do that, or at least consider it. A few years ago, Biobank did a fantastic piece of work, charting all sorts of things in the Asian community. And so it's important that we are part of that conversation as well, because without that knowledge and those statistics, it's also quite hard to know if we do have some anomalies, how we're going to treat those, right? Okay. Any more questions? Yes. Do you want to come here? Come forward. Yeah. So that's my plea to everyone that's got a question, perhaps line up here. That'd be great.
You mentioned hormonal therapy. Is that for preventative or after?
No, not so much preventative. Hormonal therapy, not in the traditional sense, certainly not like breast cancer and not things like HRT. It's more to do with immunotherapies and specific enzymes or hormones that are targeted that cancer cells will sometimes demonstrate. And that's why when you have a biopsy taken, or if you have your operation like Prithiben, it all goes off to the lab for them to look at properly. And there are specific receptors or markers that they will look out for, which mean that it is more likely to respond to a certain sort of medication. So it's not hormone therapy in the same way we talk about breast cancer, for example, and hormone therapies after that. But it's more targeted treatments that are available now. Yeah, so there are more options.
Are these treatments available at St. Mark's then?
So okay, so there's a couple of things, and it'll answer. So Prithiben's earlier question about, there's an earlier point about research. So if you have the opportunity to participate in the research, you should definitely, because the UK is probably the most regulated of countries, and research studies that get to the point where patients are involved have been through a very rigorous process. So the risks have been really well studied and looked at. Partly because of that, there is probably less available in the UK than in Europe and the USA in terms of immunotherapies or additional therapies available on the NHS currently. That will change over the next 5 to 10 years. It's more to do with the regulation and the guidance behind it. And there are certain things that you will be offered immunotherapies for, even on the NHS, I'm sure at St. Mark's, but pretty much wherever you live, in terms of once you see an oncologist. But they are not the full remit of everything that is available, say if you lived in the US.
Thank you.
Anyone else? Okay, we're going to take the gentleman.
I'll ask last.
Yeah.
Shall I ask last? Let you be the
Question is, I understand.
Yeah, the question is, as I understand, the FIT test will only detect blood. And once the blood is detected, you will rule out everything else and see what is causing. And if it's cancerous, then is it not too late for that? I mean, not too late, but is it not that the cancer has progressed so much that it's now causing you bleeding? That's the first thing. The other thing is, do all polyps detected on your colonoscopy are sort of cancerous or not?
So as I understand the part of the question, let's not mix them. So first of all, when there is a blood in the sample, you get invited for the next procedure to find out if it's a growth or it became cancer. And either way, like you are in the best hand, as Preeti also mentioned her experience, that if there is a cancer, you will get treated. Like whoever gets detected, they will get treated. And sorry, the next question was like about if it's cancerous, and because of that, if there is a blood. So either way, you will get treated by the next step in the procedure.
No, treatment I can understand. Yeah, once that cancer is detected, there is always treatment for that one.
Yeah.
But that polyps,
Oh,
that
yes.
polyps are right. Okay, put it the question another way.
Yeah.
All polyps are not cancerous.
No.
No. But cancers, cancer causes polyps. Is that right? Or is there any other thing that we detected in the system?
So polyps. So if you have normal cells, ekbaju, sao normal, and on this side you have cancer, polyps are somewhere along that line. So some polyps are early polyps, some polyps are closer to the cancer side. But generally speaking, polyps mean that there is an abnormality in the cells. Yeah. And if you leave them long enough, they will become a cancer. Okay. There's a small number of colonic polyps that are not really cancerous at all, but they're a small proportion. How quickly will they be? So if you find a 1 centimeter polyp and you take it out today, it's difficult to say whether if you leave it for 10 years, will it have become a cancer or will it be a year? It's really difficult to predict that. And there are some things, again, under the microscope that tell them, yeah, this is a fast growing, and if you leave it, but it's really difficult to tell. But it's better and it's more easily treatable earlier on. With regards to the blood question, actually, the other reason for screening is you see the blood. Okay, you go to the wipe, you see some blood. Actually, screening and the FIT test is also to pick up blood that you can't see. So if there is a very microscopic amount of blood, you may not see it, but when they run the tests, it's visible there. And that's a very early sign of things like bowel cancer. Now, not to become too technical, if you have a bowel cancer that they find that is right near the bottom end, so near, it's going to start bleeding. You're going to start noticing that blood much earlier. But if your bowel cancer is sitting all the way on this side, near where your appendix is, so actually you won't see the blood. You might start to feel tired because you are losing little bit of blood, but you won't see it. And then you do the FIT test and it shows this positive. So it's not just that it's too late if you find that. It's another thing to try and help pick it up.
Okay. So one more question on your statistics. You said 2%, when this FIT test is done, only 2% are found to be having cancers, right? So of the 2%, is there any statistics to say, right, that is the fourth stage, or is it just the beginning? Does it indicate anywhere?
So the data I showed, it tells you that let's say the 7 get invited for next procedure. So that could be because they had blood in their sample because of any other reason. And then the 2, you said that cancer, they get diagnosed. So there is no like reference at the moment with me that I could tell you that, yeah, it is cancer or like what happened after that. But they are still curable. Like it's not that they had death or something.
No, I think in your statistics, the last slide you showed, you said, yeah, 1 out of them, they are detected at 4th grade.
So overall, the numbers in the UK, and again, I'm not going to give, I don't know, overall in the UK, the last set of full data that has just come out is for 2023. And the trend over the last 5 years, and it's not, is that, so I think that the number, and I'm not, has gone from 39% to 42% of stage 1 and 2 cancers. So it's a little difference. It's only 3%, but it is a small change. And that's partly because of screening. So we are picking that, we're still picking up the same number of cancers, but the percentage that we are picking up that are still earlier is slowly creeping up. And that's important because it's more treatable the earlier you pick it up. So I think, again, if we're talking about this in 10 years' time, when screening is fully established, when all of you and all of your children have done their screening tests, that number should be closer to 50%. Because it means we're picking it up early. Yeah.
Yeah, okay, thank you.
So who here has never done that screening test?
So I hope there's somebody on the phone line tonight.
Right, any more? Oh, one at the back there.
Hi. Yeah, if you have like ulcerative colitis, how do you know that when you go for your colonoscopy every 2 years, they're looking for something to do with that rather than like with cancer? Or do they like look for both?
So they look for both. And actually people that have Crohn's and colitis, so Crohn's disease and ulcerative colitis, will have regular screening intervals. And for ulcerative colitis, it's every 2 years. So it should be every 2 years. And in addition to just looking, so now, now we are at a stage with technology that is not just what I see when I'm doing the colonoscopy, computer generated models, AI. It examines the whole of the colon. In theory, they take biopsies, because actually sometimes you can get abnormal cells that don't look like anything, but you take biopsies of the area and they come back as abnormal. So actually the process for ulcerative colitis screening is even more. And it's to try and pick up that change from just inflammation and colitis to starting to become dysplasia and abnormal cells.
And how do you like not confuse your symptoms from ulcerative colitis or Crohn's to cancer?
Really difficult question. So if you know you have ulcerative colitis, so initially some people will present with symptoms and then they don't know that they have colitis. They get referred either through their GP or the concern is as a cancer, but actually we don't find a cancer, but we find evidence of colitis and then they get started on. After that, it's regarding flares and medications and how you manage the symptoms. But generally speaking, if you have a flare, as it were, and it's not getting better with the treatments, the question should always be, is there something else going on? And although I say it should be every 2 years to have screening, it doesn't always happen. The system is not infallible. Patients get missed and lost, and ulcerative colitis particularly is younger patients. And sometimes it's not top of their priorities to say, you know what, it's been 23 months and I haven't received my appointment. So sometimes you leave it for 3 years. And I think that it's important that if there's any changes, if there's anything that's not responding, you should flag that up to your gastroenterologist or the IBD nurses.
Thank you.
I think we've got time. We've got time for one more question. And then we are going to wrap this up. I think we've got one here as well and one from there. And then don't forget, I've got some information here. We've got those wallet cards and a piece of loo roll for you to take home.
Hello, everyone.
Yeah, Rakopai.
The thing I'm thinking is people are put off going for screening and testing mainly because of the harsh severe treatments, the following positive diagnostics and surgery. They go through severe chemotherapy and radiotherapy, and the side effects are so harsh that they feel that they don't want to live anymore.
Prithiban, perhaps you want to give us a little bit of insight into that, given your own experience.
You make a very interesting point, and yes, that thought will cross your mind as to do I go through the treatment or do I not? It's natural. I can give you an experience from, I've had this cancer second time. The first time round when I had my cancer, the chemo was so difficult. I had chemo every week for 6 months. And it was intravenous. I'd be at hospital for the whole day. I was really nervous going into this, for the second surgery. And when they mentioned the second chemo, I was like, oh God, no, I don't want to do this. But they all told me, oh, it's a lot easier than your first one. And I can see now, yes, it is easier. I'm doing everything. I'm going out. I'm able to do everything that I want to. I'm active, go for walks. I haven't lost my hair, whereas I did for the first one. So I think you have to make a judgment call yourself, because if you don't have the surgery, if you don't have the chemo, if your cancer is aggressive and fast, you'll have a limited time here. Whereas this way, at least, I may have a few more years, to be able to do all the things I want to do. So it's a personal thing.
Thank you. Last question.
I think it's really important that you ask those questions and that decision is right for you. And I know a lot of people say, okay, anebo was mulai to chemotherapy. Every person will react differently. Chemotherapy has come a long way from what it was even 10 years ago. Chemotherapy for bowel cancer, and I'm not talking from dietetics, but is generally gentler than what it is for other things. But ultimately, if that is what sits right with you, okay, you don't want the specific treatment, you want the operation, but not, that's fine. But you've got to ask the questions, you've got to talk about it, and you've got to be clear what the decisions is, and you will still be supported through all of that, because some people decide not to have curative surgery, curative chemotherapy, and there are pathways for that. You get referred to the Macmillan Nurses Palliative Care, so that there are other symptom control things that are available to you through the NHS.
Take one final question and then wrap this up. So I think, Tamara, question, Chair?
I'm only allowed one.
You're only allowed one.
Well,
So
then
choose the one you want answered.
Okay, then I'll ask the question about myself rather than the one that I want to ask in general.
Yeah.
But I can ask him later. Okay.
Although, if you are receiving medical treatment
No,
already,
I'm not.
You're
I'm
not.
not.
Okay,
No.
fine.
Okay. All my bowel screening is normal. I've had several. Yet, because I'm housebound, my GP came home. Because what I found is recently, my pads that I wear are clear, but they're wet from the backside. It's colorless. Sometimes it's shiny. And they have referred me to colorectal surgery department. I had an appointment on the 26th of May of next year. Then I had an appointment for next Tuesday, and I've just received a text this evening to say, sorry, we've canceled that and you're way back again to May 2026. How do I overcome that?
I know. And that's it's a difficult question, because clearly, so we talked today a lot about bowel cancer. We talked about cancer, okay? And a cancer is something that gets the headlines. And as I said to you at the beginning, you get referred for a cancer, you get seen very quickly. A lot of this stuff gets happened quickly. Unfortunately, there's lots of other things related to the bowels that can be a problem. And for the individual involved, it is a big problem. The state of the nation overall means that waiting times for appointments and things are very long. Okay? And there's no way of getting around that, unfortunately. And as much as there's an emphasis on cancer care, all of the non-cancer services, so cancer and emergency care in the NHS probably are what hold it up overall. But all the other things, the routine things, sometimes there's long waiting times. I think if you want to stress the challenges it's causing to you, that's all you can do. You can talk to the GP, you can talk to the place where you've been referred to and explain that, look, this on a day-to-day basis, this is impacting significantly, and try and get your appointment brought forward.
Yeah, I'm going to ring tomorrow.
I was going to say, I can't promise that will happen, but that's really all you can do. And your
They can
GP may be able
fast-track
to
me, can't
support.
they?
They can fast track you if you get referred as a 2-week wait. That's really the only fast track option available. So as a suspected cancer. And then that boils down, so that's what I'm saying is either the emergency going to A&E or being referred for a cancer are the two areas where the NHS probably does really well. All the other areas currently with funding, with resources, with people mean that actually people are waiting for a lot longer. People are waiting for knee replacements for over a year. And then that is.
Yeah, but then you have an option to put your hand in your pocket for that. For this, you don't.
You can see people separately and outside of NHS waiting times for that. You can go and see a private, colorectal surgeon privately. I presume that's what you mean by putting your, yeah, you can do that, but it shouldn't, in my opinion, that shouldn't be the way we need to go. But unfortunately, the NHS overall is in that position.
Yeah, but for your hip, that hip or knee or whatever, you're going to spend an X amount. For cancer, you don't know. You could be.
So if you're worried about cancer, then you say to the GP.
I'm not worried about cancer because my bowel screening is normal. They've done about 4 or 5.
Yeah. So in order to get initial tests and investigations done, if you're worried about cancer, your GP refers you as a suspected cancer, and you will get seen along that pathway. If you're not, you can see somebody else separately, and probably sooner than what you would see on the NHS. Okay. It's difficult. There's no ideal answer for this.
One very crucial question. I know what endoscopy and colonoscopy is. What is a colonography?
Colonography, yes. No, colonography is, so I touched on it briefly. That is 2 questions. CT colonography. Generally, it's what they do if either you are not fit for a colonoscopy or they feel that in some places they do them routinely anyway. They don't do colonoscopies first. They do, you have to clear your bowel. You have a little tube where they put air into your bowel, and then they do a CT scan. And it will show up a lot of things, but the disadvantage is that you can't take biopsies if you've seen something. So then if you have a positive finding, you have to go on and have a colonoscopy anyway.
Thank you.
So that brings us to the end of our evening here this evening. Thank you all very, very much for attending. I hope it's been helpful and useful. And do please take the wallet cards from here. And once again, huge thank you to Sujay Bhai and to Benazir. We will, of course, thank our partners at RM Partners and the NHS Cancer Alliance for giving us the grant to be able to bring these talks here to Ekta Center. And Priti Ben, thank you so much for your really open and heartfelt conversation. And I hope it's inspired many more people to actually step forward and share their experiences with us. I was telling you all about this. So who wants a piece of this? Come and get it from here. I will just say a huge thank you to the tech team. So Bhupesh Pai and Nishal, who's helped us this evening. This is all on YouTube, so we will be able to see it again. Please do help stack the chairs in 5s, and then they'll be taken to the back of the hall. Thank you very much.